Hi, everybody, and welcome to our module on pediatrics. Pediatrics is the medical care of children, so I thought before we talk about that, we can talk about how children enter the world, and that is through the process of labor. Labor refers to regular uterine contractions that develop in women in the late stages of pregnancy. This leads to progressive dilation and effacement of the cervix and eventually descent and expulsion of the fetus. So if you look at the bottom of the screen, on the left side is a woman who is pregnant, and you note that her cervix is closed, meaning it's a very small hole. Her cervix is also very thick. What happens during labor is that the cervix dilates so that the baby can enter the birth canal, and it also thins. You see how it's much thinner here than in the other picture, and that's the process of effacement of the cervix. It thins and it also becomes more malleable so that the baby can move through it. Labor is divided into stages, and this often comes up in the step one exam. It's very easy points. You just have to be able to name or identify the stage of labor that a woman is in. So stage one of labor is from the onset when the contractions begin until the cervix is dilated to 10 centimeters. That's this process we're talking about here at the bottom of the screen. Stage one is sometimes divided up into the early labor phase. That's the onset until the cervix is dilated to 3 centimeters. The active labor phase, which is 3 centimeters to 7 centimeters. And then finally, what's called the transition phase from 7 centimeters to fully dilated at 10 centimeters. Stage two of labor is the delivery of the baby, and finally, stage three is the delivery of the placenta. So here's a picture from Wikipedia showing stage two and stage three. So the baby moves down into the birth canal and is ultimately delivered. Then after the baby is delivered, remember that the placenta remains behind, attached to the baby by the umbilical cord. The umbilical cord is cut and the placenta is gently pulled out, and that is stage three of labor. And when you do your OBGYN rotations as a medical student, your job will probably be to gently pull the placenta out after the baby is delivered. APGAR scores are a number that are assigned to children at the time of birth, and they're meant to represent the overall health and well-being of the newborn baby. They're assigned at 1 and 5 minutes after birth, and the score goes from 0 to 10. So for each of these items shown on the screen here, heart rate of the baby, respiratory rate, muscle tone, reflex irritability, and color, the baby is given a score of 0, 1, or 2. If you have a 2 for every one of these 5 items, then you will have a score of 10. 90% of newborns have scores in the 7 to 10 range, and that's good. Scores that are less than 7 require further evaluation. They don't necessarily mean something is wrong, but they mean that the baby needs to be closely monitored and evaluated to see if there's anything that should be done to improve the baby's overall cardiorespiratory function. And here's a chart from Wikipedia just showing you how the APGAR scores are assigned. So for example, for heart rate, there's a score of 0 if there is no pulse. Below 100 is 1 and over 100 is 2. And then for all these other items here, respiratory effort, muscle tone, reflexes, and the reflexes include whether the baby grimaces or coughs or sneezes. And then finally color, a 0 is blue or pale and 2 is completely pink. Many babies have low APGAR scores and then go on to recover and develop normally. So a low APGAR score doesn't necessarily mean the baby's going to have a developmental problem. But the feared outcome when the APGAR score is low is cerebral palsy. We'll talk about that in a minute. It's permanent neurologic damage. Most infants with low scores will not develop cerebral palsy, but the risk is higher if their scores are lower. The two scores, the 1 and the 5 minute, have a little bit different predictive ability. So the 1 minute score does not predict outcome at all. It's not been shown to do that. And a lot of babies can have a low 1 minute score and then recover by 5 minutes. If the 5 minute APGAR score is 0 to 3, which is very low, this is associated with an increased risk of neurologic damage. But once again, it doesn't necessarily mean the baby's going to have permanent neurologic damage. Cerebral palsy is a permanent central motor dysfunction syndrome, and the key word is motor. This is not a sensory problem. It has to do with movement and things like muscle tone, posture. If you've ever seen someone with cerebral palsy, it's sometimes difficult for them to walk and maintain their balance. It's non-progressive, and what this means is it's present at birth and remains that way. It doesn't get worse over time. It's caused by damage to the fetal or newborn brain, and it can be caused by asphyxia of the baby at the time of labor. This is lack of oxygen to the brain. Now, usually, and in most cases, this is not the cause, but because this is a potential cause, children born with cerebral palsy often generate a lot of lawsuits against obstetricians. In fact, if you Google the word cerebral palsy, what will come up is a list of lawyers who can help you with a lawsuit. So this is what can happen in babies who have persistently low APGAR scores. This is the feared outcome. So now that we've talked about how babies enter the world, let's talk about how they normally grow. So, growth in children usually occurs in a predictable course, and it's influenced by nutrition and general health, as you can imagine. There are three key metrics that pediatricians monitor in terms of growth. Every time a baby or a child goes to the pediatrician, they are weighed, their height is measured, and until 2 years of age, their head circumference is measured. And we'll talk about this in a minute. These are compared to norms for the child's age group, and often the weight or height or head circumference is reported as a percentile, 10th, 50th, 99th. And this means among similar children their age, is this child normal? Normal would be right at 50 percentile, high would be at 99th percentile, and low would be at 10th. The child's height, weight, and head circumference is usually plotted on a growth chart to determine the percentile. So this is a growth chart here for weight. You'll get very familiar with these on your pediatrics rotation. So for example, if a 14-year-old child came in to the office and had a weight of 130 pounds, that would be right here. And you can see that that's the 75th percentile. And you can plot the height, weight, and head circumference on charts like this and determine the child's percentile. Let's talk about the weight of newborn babies. It's very high yield to know that full-term babies lose weight after birth. Remember that in utero, they're getting lots of nutrition from the placenta, and after they're born, they have to get that nutrition from eating, and it takes time for them to catch up and get the same nutrition that they were getting from the placenta. So babies can lose up to 10% of their birth weight in the first few days of life. They usually gain it back by 10 to 14 days. So this is a classic board question. A baby that's lost a little bit of weight, it's not necessarily a serious medical condition. After the newborn period, infants grow very fast. They double their birth weight by 4 months, they triple it by 1 year, and children gain 4.5 pounds per year from age 2 until puberty. Linear growth is the growth of the long bones, like those of the arms and the legs. This is what's going to determine how tall a person will ultimately be. And you should know that linear growth is non-linear. Ironically, it doesn't occur in a fashion like this with a steady increase every year. Instead, it occurs in spurts with slowing, sort of more like this. The average length of a baby at birth is 20 inches, but infants grow 10 inches during their first year of life, so that's a 50% increase in their length. Children reach half of their adult height by 24 to 30 months. So this is a 2 to 3-year-old child is going to be half the height it will ultimately be as an adult. Children grow 2 inches per year from age 2 to puberty. You don't have to know these exact numbers. I'm just giving you a range here. And then there's a normal deceleration of height velocity right before puberty, followed by a growth spurt. So many children don't gain much height in the year or two before puberty, and then they gain a lot when they develop puberty. If children appear to have short stature after the age of 2, for example, if they are at the 10th or 20th percentile for height, the most common causes are constitutional growth delay. This is the most common cause. The second most common is familial short stature, which is a genetic syndrome. Basically, people who have this are just members of families where most people are relatively short. Both of these are variants of normal and not pathologic, and it's high yield to know that. A child that is not growing in length doesn't necessarily have a nutritional deficiency or something along those lines. Most likely, it's just a variant of normal. So this most common cause right here, constitutional growth delay, is referred to as constitutional delay of growth and puberty, or CDGP. Children who have this have a late adolescent growth spurt, so they tend to be relatively short up until that point in time, and then they gain some height, and they often end up with a normal height ultimately, and they also tend to have delayed puberty. So as we'll see later, this is also a potential cause of a child who has delayed onset of puberty. Shown on this slide are some potential causes of pathologic short stature. These are ones that I think are particularly high yield for step 1. So a child with short stature and pulmonary symptoms probably has cystic fibrosis. A child with short stature and developmental delay or learning disabilities may have Down syndrome. You may know that children with Turner syndrome have pathologic short stature. They also have a webbed neck and a wide chest. And then finally, achondroplasia is a chondrocyte disorder, and it leads to dwarfism, which is individuals who have short limbs relative to their torso. Head growth is monitored in children usually just until the age of 2, and the reason this is done is because it reflects growth of the brain. So if the head is not growing normally, it may mean a problem with brain development. A child who has a small head is said to have microcephaly, and there are many, many causes of microcephaly. There's a huge differential diagnosis. But for step 1, what you want to know is that microcephaly occurs in many genetic disorders, and when it does, it usually occurs together with dysmorphism. Dysmorphism means abnormal features of the body, things like abnormalities of the face or the limbs. So for example, children with Down syndrome, which is trisomy 21, often have microcephaly. They will also have all the facial and other features of Down syndrome. Angelman syndrome is an imprinted gene disorder that I talk about in genetics videos, and it is associated with microcephaly, but also many other characteristic facial features. Same is true of Williams syndrome. This is caused by a deletion on chromosome 7. I also discussed this in genetics, but it's associated with microcephaly. Let me briefly mention Down syndrome because it's very high yield for step 1. So I talk about Down syndrome in detail in the Down syndrome video in the genetics section, but I'll just mention here that in children with Down syndrome, the birth weight, the length, and the head circumference are usually low, and they usually remain low until puberty, and some children with Down syndrome even become adults with short stature. Developmental milestones are motor, language, and social skills that children should acquire by a certain age. So, for example, by 2 years of age, there are certain motor functions and language functions that children should be able to do. By 4 years of age, there is another set of milestones. If a child fails to reach these milestones, meaning they're unable to do them by the age that most children can do them, this is called developmental delay. Developmental delay has a huge differential diagnosis, but a couple of things I'll point out is there are some reversible causes. For example, hearing loss or lead poisoning are potentially reversible causes of developmental delay. And then I'll also point out once again that just like microcephaly, this often occurs together with dysmorphic features in some genetic syndromes. So children who have developmental delay, as well as facial, limb, and other abnormalities, they may have Down syndrome. This is a classic cause. They may also have Fragile X syndrome. These children have a long face, large ears, and large testes. This occurs together with developmental delay. These are two of the most common pathologic causes, non-reversible causes of developmental delay. Shown on this slide is a table of gross motor, fine motor, social, and hearing and speech milestones that children should reach at various ages, spanning all the way from 6 weeks up to 1.5 to 2 years. I won't go through all the items in this table. You can find this table in First Aid for the Boards and many other textbooks. You should familiarize yourself with the milestones, and I asked my medical students for the best mnemonic to remember these milestones by, and I got about 20 different answers. So use whichever mnemonic works best for you, but commit these to memory one way or another because it's easy points on your exam if you can identify the age that a child is at based on the milestones. Lots of screening is done in pediatrics, and I won't go through all the measures that pediatricians screen for, but I've listed a select few on this slide here that I think are important. First of all, pediatricians screen for hearing problems. That's because hearing problems often are not diagnosed until a child gets behind in terms of development. So if you can identify them early and treat them, the child will develop normally. Same is true for vision problems. Iron deficiency is screened for, which we'll talk about in a minute. So is lead for lead poisoning. Children are screened for oral health. Problems with dentition, believe it or not, are responsible for a huge number of missed school days among children. So pediatricians want to make sure a child has good oral health and is going to the dentist. Children who are 9 years of age or older should be screened for tobacco, alcohol, and substance use. Depression is a major focus of screening, especially among adolescents, children ages 12 all the way up to 21 years of age for adults. And then finally, we'll talk about poverty, which is also a screening measure in pediatrics. So the reason children are screened for iron deficiency is because up to 9% of toddlers have iron deficiency in the US. Commonly, it's caused by insufficient dietary uptake, but it also can be caused by problems in the duodenum because remember, the duodenum is where iron is absorbed. So some children have celiac disease or Crohn's disease. It may not be at an advanced stage where it's clinically obvious, but you can pick up the iron deficiency on laboratory testing. And the reason this is done is because it's easy to treat with iron supplementation. And if it's not treated, the child can develop developmental delay. The CRAFT tool is a screening tool used to screen for substance use in children. CRAFT is a mnemonic that goes for the letters of the questions you ask the child. So the C is for car. Have you ever ridden in a car driven by someone using alcohol or drugs? The R is for relax. Do you ever use alcohol or drugs to relax? The A is alone. Do you ever use alcohol or drugs while alone? The F is for forget. Do you ever forget things while using alcohol or drugs? The other F is for friends. Do your family or friends ever tell you that you should cut down on your drinking or drug use? And finally, the T is for trouble. Have you ever gotten into trouble while you were using alcohol or drugs? A yes to any of these questions is a point, and children who have 2 or more points have a high risk of adverse outcomes. So this is a commonly used screening tool, which you'll probably encounter on your pediatrics rotations. Car injuries are a major source of morbidity and even mortality among children, so pediatricians usually talk with parents about seat belts and other safety measures in a car. So newborns should always ride in a car seat that is in the back seat of the car and it is rear facing, meaning the child is facing away from the front of the car and the windshield. Toddlers and young children can sit in a car seat that is forward facing. Older children up to about 12 years of age should sit in a booster seat with a seat belt. And you should be aware that airbags which deploy in the front seats of cars are dangerous in children less than 12 years of age. So for this reason, most children 12 years or younger sit in the back seat of the car. Screening for poverty among children means screening for lack of basic needs, things like food, housing, and heat. Unfortunately, many children who are sick are also poor, and if providers identify the poverty, they can link the families with community services. So we talked about car injuries before, but now let's talk about injuries in general. So unintentional injuries are the leading cause of death among children. So pediatricians, for this reason, treat injuries the same way adult doctors treat cardiovascular disease. This is the leading cause of death, and they provide advice to parents and children to try and avoid getting into injuries. Retrospectively, when you look back on children who were injured seriously, you can find out that the injuries were often predictable and preventable. So we've already talked about car injuries. Pediatricians recommend car seats and seat belts. Firearms, meaning guns, are also a source of injuries. The best way to avoid these is gun avoidance, meaning no guns in the house. This is the most effective means of prevention. For parents that do want to have guns in the house, pediatricians will recommend safe handling and storage. And then bicycle injuries are a major source of injuries in children, and many times they are head injuries, which can be serious or life-threatening. So prevention is with bicycle helmets, so pediatricians often discuss bicycle helmets with families. So all of these things, car injuries, firearms, and bicycle injuries, are sources of injuries to children that pediatricians screen for and give counseling for in order to avoid the most common cause of death among children, which is unintentional injuries. Anticipatory guidance is a term you will hear often on your pediatrics rotations. This refers to advice given by a provider to parents, and it varies by the child's age. And the idea here is to anticipate things that are going to come up and let the parents be aware. So you can tell the parents about what is expected in the near future for growth and development of their child. You can also tell them about important safety reminders. And you should just be familiar with this term, anticipatory guidance. Your pediatricians use it very, very often. Shown on the screen is the recommended immunization schedule for children according to the CDC. No one can ever remember this unless you're a practicing pediatrician who uses it all the time. So I wouldn't worry about trying to remember when children require various vaccines in terms of age. You should, however, for step one, be familiar with the infections that can be immunized against. So these include hepatitis B, rotavirus, diphtheria, tetanus, and pertussis, Haemophilus influenza, pneumococcal vaccine. There's an inactivated polio virus to immunize against polio. Influenza virus can be immunized against. This has to be given every year. There's a vaccine for measles, mumps, and rubella, also for varicella, hepatitis A, and meningococcus. Moving on, let's talk about puberty. Puberty is the transition to sexual maturity, and it occurs in children as they go through two major physiologic events. The first one is called gonadarchy. This is activation of the gonads by the pituitary gland. The gonads are stimulated by FSH and luteinizing hormone and become active. Second major event is adrenarchy. This is increased androgens coming from the adrenal glands. So both the gonads and the adrenal glands change at the time of puberty, and a lot of people forget the adrenal glands. It's helpful to remember that in board questions. There are a number of terms that are used to describe various events in puberty. Thelarchy is the development of breasts in girls. This is driven by estradiol action on breast tissue. Menarche is the first menstrual period. Spermarchy is the first sperm production. This is often followed in males by a nocturnal emission. That's usually the first ejaculation. That's because the parasympathetic nervous system is very active at night. That often leads to an erection. And when boys are beginning to develop sperm, that's often when the first emission occurs. And finally, puberchy is the development of pubic hair. This is primarily due to androgens that come from the adrenal gland at the time of puberty. Puberty can be described by Tanner stages. These range from Tanner stage 1 to 5, and this assigns a number to the pubertal development of the child. There are separate Tanner stages for the male genitalia, the female breasts, and the pubic hair. So for example, a child can be Tanner stage 1 for male genitalia or Tanner stage 3 for pubic hair. Stage 1 is prepubertal, so children who have not started puberty are always in stage 1 of the Tanner stages. And stage 5 is full adult sexual characteristics. This usually occurs in most children by age 15. Shown on this slide are the Tanner stages. On the left are the Tanner stages for male genitalia. Stage 1 is prepuberty. Stage 5 is full adult male genitalia. Stages 2 through 4 are in between. On the right side of the screen, we have female Tanner stages. We have the Tanner stages for the breasts and the pubic hair. Stage 1 is prepuberty once again, and stage 5 is full adult sex characteristics. Precocious puberty is very rare, but it often comes up in board questions because it is a way to test your understanding of the sex hormones. Precocious puberty occurs at an early age, usually before 8 to 9 years of age. In boys, it's caused by excess androgens, and in girls, it's caused by excess estrogens, and this is what you want to remember for step 1. In boys, one of the classic pathological causes in terms of board questions is congenital adrenal hyperplasia. I talk about this in more detail in videos in the endocrinology section, but children who have one of the most common forms of congenital adrenal hyperplasia synthesize excess androgens, and if that occurs in a boy, that boy will start puberty at a very early age. And then finally, we'll finish with this slide. Delayed puberty refers to no evidence of puberty by age 12 to 14 years. And as I mentioned earlier, when talking about short stature, the most common cause of both short stature and delayed puberty is the constitutional delay of growth in puberty. This is a normal variant, and these children will usually eventually enter puberty. In terms of step 1, what you want to remember is anyone with delayed puberty has underproduction of androgens and estrogens. This is what they're going to want you to know in terms of mechanisms. So this can be caused by hypogonadism, meaning underdevelopment of the gonads. In girls, the classic cause is Turner syndrome. In boys, the classic cause is Klinefelter syndrome. Children with either of these conditions can have delayed puberty because their gonads are under development. And then a rare cause, but one you should know for step 1, is Kallmann syndrome. Children with this syndrome have a GnRH deficiency, so there is limited GnRH coming from the hypothalamus to stimulate the pituitary gland. They also have anosmia, a very unique and unusual feature. And that concludes our video on pediatrics.